So it is my pleasure to be here with you today at the Stanford Biodesign Retreat and share with you some of the exciting technology and help that we are getting from the Pure EP system. Specifically, we will be discussing the value of the high-fidelity information and recording during our ablations. I will go over my disclosures briefly. These are my disclosures. Reviewing the background of the Pure EP system, as you know, it made a huge difference or a new method of acquiring and filtering signals. As for the traditional recording system, it takes the raw information and applies multiple layers of gain, amplification, and filtering, and displays that in a way there is an analog filtering going to digital conversion. While the Pure EP system is taking that raw information and essentially have a fixed gain with a digital filtering that preserves most of the physiologic information. To drive this point, we'll go ahead and talk about a couple of the advantages of Pure EP system. With that new recording, you would have a higher signal to noise ratio and more information by acquisition of a wider range of amplitude and frequency due to this linear acquisition versus a logarithmic acquisition with the traditional recording system. Specifically, using the high frequency algorithm to detect physiologic versus noise is one of the big advantages. I will share with you a couple of cases, starting with an atrial fibrillation ablation on a 73-year-old patient. This is a lady who had recurrent episode of AFib, not tolerating very well medical therapy. So she was brought for a cryoballoon ablation. We had the standard setup with the cryo system and a CS catheter. And as you can see, when we approach the left superior pulmonary vein, advancing the achieved catheter into the upper branch, you can see there is definitely pulmonary vein potentials and the left atrial recordings as far field. However, some of these signals were difficult to assess. If you focus here on, let's say, achieve 1, 2, in a typical recording, you would be confused whether this could be noise or not. While you look in parallel to the high fidelity component, there's no question that this is mirroring a physiologic signal, and you know this is a good target of ablation. This is a little bit more significant in the second example when we actually target the lower branch of the LSPV. And here it's a little bit trickier. If you look at this zoomed in signal here on the achieve, you could really argue that this could be nothing or noise, especially we were doing this case in our new lab, which unfortunately has a lot of noise. But as you look at the high fidelity component, you would know that this is definitely physiologic. There is remnant PV potential, and you should do more ablation in this area. Switching gear, I will show you a second case where we did a VT ablation on a 75-year-old patient with an ischemic cardiomyopathy, multiple VT, not controlled with amiodarone. He had no previous ablation. For this procedure, we had multiple catheters, his, yes, RV, and ICE. We did use our contact force ablation catheter for further mapping and targeted ablation. And as we were working, we did induce his first VT. That's a left bundle VT. And after mapping, we identified some diastolic components. The beauty of this recording is, as you can see, we were ablating here a significant artifact because of the ablation on the catheter, and you would have difficult time to detect what is real and what is actually artifact. As you look at this mirror, the high fidelity recording, you can definitely identify what are the electrograms that are on the ablation catheter and that are worth pursuing. As after we ablated the initial VT, we actually induced a second VT, and here, much better, you could see a diastolic component. There's an intermittent actually contact here, but again, the high frequency recording can tell you that this is a diastolic potentials, and this is an area worth pursuing and treating. So as we demonstrated in these, the high fidelity component identify critical signals and help you essentially determine whether this is physiologic versus noise. This has a huge potential in improving your clinical workflow and eventually could lead to an improved procedural success. I can tell you at this point, I would not ablate the PVC's BT or atypical flutter before looking at the pure EP system and confirming signals prior to ablation. Thank you so much for having me, and have a great rest of the day.